Good morning, everyone. My name is Ellen Vera, and I am a specialist with our Provider Outreach and Education Department. With me on the call today is Rachel Wood, who is a nurse analyst with our Provider Outreach and Education Department. And we also have some members of our medical review staff on to listen, to see the information we're providing, and then they can help respond to questions if we're not able to answer those. I do want to talk about one pre-submitted question that we received for this presentation today. And the question was whether or not services could be provided incident to under the incident to guidelines within a patient's home. And we covered this in the presentation that we did on Tuesday. We went through some of the different rules for home services and really went in depth on incident to. So the short answer to that is yes, we will have that presentation available as an encore on our YouTube channel and also available on our website here within the next few days. There are criteria that you have to meet for incident to if your practitioner, your billing practitioner is not in the patient's home. And that information, again, was covered pretty in-depth within that presentation. Another pre-submitted question that we received both for the presentation on Tuesday and this presentation is, what are the requirements for documentation for services within the home? Well, there's no particular requirements, for a provider to do evaluation and management services in a patient's home. And there's nothing else that you have to have other than the medical necessity of your service, and then documentation in order to support the level of service that you have provided. So your patient doesn't have to be homebound. They don't have to have anything in particular for you to do services in their home. You do those just like you would do a service within the office. We've provided our disclaimer here today just as a reminder that this information is as accurate as we can make it for today. Medicare rules and regulations do change often, and the publications and the rulings from CMS are the final determinants of coverage along with your documentation. We will provide responses to your questions based on how you have asked us the question, but the Medicare rules, again, will determine final coverage. And then CMS does prohibit recording of the presentation for profit-making purposes. So if you are recording this presentation or doing screenshots, we really would ask that you not do that. Again, we are recording this presentation, and barring any technical difficulties, we will have this available on our Encore page on our website, and then also in our YouTube channel. The other thing I want to, well, two other things I want to say here before we dive into the documentation itself. Number one, as you're aware, evaluation and management services can be more subjective than other procedure codes. In looking at documentation and looking at the AMA rules concerning how you code and looking at the CMS rules, there's a lot that goes into that. So through this documentation, or through this presentation today, we've gone through the documentation that we have, and we have determined procedure codes based on that. If you are down-coded or up-coded for that matter, if the CERT contractor, the special medical review contractor, recovery audit contractor, WPS ourselves, if we are changing a procedure code that you have submitted, you have the right to an appeal. If you don't agree with us, then appeal it. What you want to do in that request for appeal, though, is you want to be specific in your request as to why you believe your procedure code, what you submitted, is the procedure code that should be applicable to that particular service. A statement that you include on your appeal request about, see attached documentation, something along those lines, that's really not going to help you. What you want to do is you want to say, look at section, whatever section, on page 3 of the documentation. We believe that this supports whatever level of problem, data, or risk that there is. Or look at page 5 where we have time that is indicated, and we coded based on this time. Be very specific with us, because for all of these contractors that I've mentioned, if we have changed that procedure code, it means we've already looked at the documentation and we believe that the procedure code we have assigned is the correct procedure code. Doesn't mean that we're always correct. We're people just like anybody else. But when you request that appeal, you want to be specific. Again, the statement, see attached documentation, really is not helping you. The other thing that I want to mention before we dive in is that home services, as you're aware, are not as common as office services or inpatient services, etc. So in looking at the documentation that we had available to us, we really only had one request for an appeal that had been submitted with documentation. So we reached out to some early registration people for this presentation today, and we did have a member that provided us with redacted documentation, and we really want to say thank you for that. Otherwise, we would not have been able to hold this presentation at all. So now let's dive into the documentation itself. So here we have example 1, and we have patient history here. So we have psychiatric history. Patient denies any family history of mental illness. It provides information there on past employment, substance abuse, past psychiatric treatment, etc. What I want to call your attention to, though, is the code status that's listed there at the bottom of this page. It shows that the patient is full code. That's going to become important when we look at further documentation. Now we have information concerning this patient, and based on my reading of this, it appears that this patient is a recent patient within this assisted living facility. Now, we don't have documentation that tells us that directly. That's really just my opinion of the documentation itself. So we have our chief complaint here, and it's a medication management for an adjustment disorder with mixed depression and anxiety. And then it provides the medication, the Zoloft, and then the amount that she's taking every day. So this particular encounter with this patient is for that medication management of that adjustment disorder. So the documentation is going to be kind of geared toward that depression and anxiety, and then looking at that medication. It does tell us that the staff report the resident is at baseline. She's evaluated in her room. It does indicate that she's in no apparent distress. She is continuing to eat her meals in her room, as she's still uncomfortable going to the dining room. Her sleep is stable. She is waking up multiple times during the night to go to the bathroom. She does have a urologist appointment. The unknowns of the future and what will happen at the appointment is causing increased anxiety. She also reports anxiety related to how her kids will feel if she passes away. She indicates that she's over her depressive symptoms. She enjoys spending time with her daughter, has a good support system. She doesn't have any suicidal or homicidal ideation. So again, the patient is within this assisted living facility, um, it indicates that she is stable. It indicates that um, this provider has talked to the staff concerning this patient, and then of course, it indicates some anxiety concerning her children. The next thing that we have then is what it states is external records. So it talks about the fact that this provider has received information from an independent historian. Now, that piece of information could be valid and could be used in order to choose your procedure code, except that the rest of the information does not support that. So if you'll notice on here, that independent historian is listed as the staff, but then it goes on to say that is the patient unable to provide a complete or reliable history? And the answer to that is no. So that's one of the qualifiers for being able to use the fact that you talk to an independent historian as part of your choice of your level of service, is whether or not the patient is unable to provide a reliable history. In some cases, you have patients who won't be able to, either because they're just kind of not aware, because of dementia, because of whatever, and you need to get information from somebody else. That somebody else could be the staff, just like this is mentioned here. It could be family members. But because the physician has indicated, or the practitioner has indicated that the patient is able to provide a complete and reliable history, we did not consider the independent historian as part of our choice of the level of service. It also indicates in here that a confirmatory history is not needed for this patient. Patient is telling the practitioner that they have a good support system in the fact that they have wonderful children. And I think most of us would probably say that about our kids too. So then we have our current medications. We have the Zoloft of the 25 milligrams daily. It indicates there that they are going to continue this. They believe that the resident is benefiting from this current dose. They do also indicate dose reduction attempt at this time would risk decompensation of the resident. Now, I think that's a fairly strong statement, and I don't necessarily believe that that statement goes along with some of the other indications that are within this documentation. Now, that doesn't kind of change anything as far as choosing the level of service goes. But really, when we're kind of looking at and evaluating this, it looks like this is more standard language as opposed to language that is specific to that individual patient. So the next thing that we have then is the mental health exam itself. So we have our appearance and behaviors listed there. Patient is calm and cooperative. We have orientation. The patient knows where they are. They know who they are. They know the date and time, that type of thing. The patient's mood, and frankly, I had to look up this word euthemic. Means that the patient is optimistic about the future. Their thought processes are organized. They're not having hallucinations, anything else. Their judgment is good. And then again, suicidal and homicidal ideation, the responses to both of those are no. So when we took a look at this one, we decided that the procedure code should have been a 99347. Now the claim was billed at a higher level. We determined that the problem was straightforward. The patient is reporting anxiety about an upcoming appointment and her children if she passes. There's really no information, though, on a degree of anxiety, and it doesn't appear that this is causing any problems within her daily life. We don't have any information on how long this may have lasted or how long it is expected to last, whether it's better, whether it's worse. And the patient did report that she was over, and I'm quoting, over the depression. For the data, we don't have any testing. The documentation does not indicate the practitioner is providing any mental health testing, such as a PHQ-9. The documentation does show information that could relate to that as part of the exam. Even if we considered that exam as similar to a PHQ-9, it would still only be one test, and that would leave it at the straightforward. For the risk, we also went with straightforward on this. There's no documentation to support a risk to the patient from the decision to continue the medication. I think that's one area where providers are having some difficulty. The fact that the physician or practitioner is ordering a medication does not always mean a higher level of risk. When you're evaluating your risk, you're looking at the risk to that patient from the conditions that are being treated and the medical decision plan that that practitioner has made. In this case, the practitioner has indicated that it is a continuation of a medication that the patient has already been on. Again, we don't have any length of time, how long the patient has been on that, anything else. And there's no indication from the practitioner that the patient is placed at any type of risk from continuing to take this medication. So our procedure code is the 99347. If we go on to the next one, then this visit is on the same date for the same patient. And so our denial, we actually denied one of these two services, is because both of these services were provided by a nurse practitioner on the same day. In order for Medicare to allow that, there would, well, in a situation like this, Medicare pays for evaluation and management services on a per diem basis. So in order to meet an exception to that rule, and those are pretty rare, the services would have to have been not related and not able to be provided at the same time. The services here are not related. The patient is being seen for right knee pain. However, there's no reason why both of these nurse practitioners could not have addressed both of these problems at the same time. The other thing I want to draw your attention to here is the code status as listed on this piece of documentation. This one is showing it is a DNR, no CPR is supposed to be done. So this is really kind of scary for this patient. The other one shows that the patient is full code. This one is showing that the patient is not, is DNR. There, no CPR would be done. So the problem with this is if the patient actually does run into a problem, then which piece of documentation are we going to be looking at? And how is this listed within the patient's medical record with that assisted living facility? Excuse me. Just based on the information that's listed within these two pieces of documentation, I would really think that the patient is a full code. And so, you know, I'm not for sure where this information is coming from, but something to think about within the medical records. When things are kind of not matching up, this could really cause a problem for the patient depending on which piece of documentation they're looking at. So the patient is being seen for right knee pain. This knee pain did not start after the other practitioner saw the patient. the patient is indicating that they have the right knee pain. There's increased urination and incontinence. 89-year-old female has a history of primary hypertension, and then other things listed there. States that she twisted her right knee a little bit, trying to get up and around because she's going to the bathroom so much. There's no swelling or tenderness in the knee. She talks about when she has fallen in the past, and she's just afraid to fall. At 89 years old, I kind of don't blame her for that. She does deny any pain or shortness of breath. So we have the information here about the primary hypertension, hypercholesteremia, etc. But we don't have any information about how long. We don't have any information here about when she twisted her knee and how long the pain has been going on. We also don't have any information here about that degree of pain. Is she in excruciating pain from her knee? Is it just, she kind of notices her knee and it hurts a little bit? Those pieces of information can make a difference in the coding that you do from the medical record. So you want to go back to your practitioners when you're looking at documentation such as this and see if they have that information. Okay. We have the exam of the knee, no edema, full range of motion. So we can see here the general well-developed female. We have the falls risk assessment. It talks about if the people there have kind of dived to the ground on that, have just fallen down without anything else. Those are the things that they're going to be looking up for, making sure that this lady is still going good. So then we have the plan that's listed here. You'll want to notice that we also have a left shoulder pain, listed here, but there weren't any addresses or about that shoulder anywhere else. They've provided instructions here on using a lidocaine patch and Tylenol. There's a plan to increase the oxybutynin that they're taking, and they're mentioning that the patient is waiting on an appointment for the urology situations. Now, that was a little silly, the fact that the shoulder pain is listed over here, but it's not listed anywhere else. And there really isn't a lot of information about the knee other than taking some additional Tylenol for the pain in her knee. So on this one, the procedure code that was submitted was the 99349. We determined that the appropriate procedure code for this was the 99348. The patient is being seen because of the knee pain. From the documentation, it seems that this is fairly new, although we don't know when that started. The plan goes into the information concerning the shoulder pain, but it doesn't mention to us how long that has lasted. There was no exam included in the documentation. There was no history on that shoulder pain. The patient does mention increased urination, and we counted this as one acute uncomplicated illness or injury for the knee pain. The patient has an appointment with a urologist concerning the increase in urination. The practitioner is making a change in medication for that increased urination. The documentation, however, does not show how long this has lasted. Under the data, we have no indication about any testing performed or ordered for this patient. Under the risk, the documentation really does not provide any information about risk to the patient for using the Tylenol for the knee pain, the lidocaine patch, which is going on the shoulder, or the increase in the medication for the increased urination. Remember that prescription drug management is an example from the moderate level of risk, but the determination of whether it is a moderate level is a risk to the patient from the problem and the treatment options themselves. So just some additional information. Example number 2 and example 1 and 2 are for the same patient. We talked about the code status for as reported by each of these practitioners. Both services were provided on the same day. Both services were provided by nurse practitioners that are part of the same group. As I mentioned earlier, unless the services were unrelated and could not have been provided at the same time, then Medicare would combine these. Or actually, Medicare would ask that you combine the documentation and then submit the procedure code that reflects the services provided by both of those providers. Again, we talked about the code status, which, is really kind of a concern of mine. Nurse practitioners do not have subspecialties with Medicare. The 2-digit specialty code simply indicates that they are a nurse practitioner. Okay, now let's look at, excuse me, at example 3. So this indicates to us that this is a follow-up visit. They're addressing an A1C performance on 9/15. We don't know who ordered this or if it was counted in a previous encounter. We have information on the left shin indicating that it is pink and warm. We have a status of chronic left calf edema. Again, we have no information on how long this has lasted or how long that they expect it to last. The AMA definition of chronic is that it is expected to last at least 12 months or until the death of the patient. So if we're using the terminology for chronic, we need to address that time frame. The documentation indicates that there's no worsening of that today. We don't have any information whether this left calf edema is at goal or not. Is this what they anticipate for the patient and where they want the patient to be with that left calf edema? The patient is also reporting chest pain within the last week. This is the 3rd time that they've had that, but the first time that they have actually alerted the practitioner. So now we have information about the patient's physical exam. We have a high blood pressure. You can see there 156/57. The patient at this time appears in no distress under that general category. We have information on the lungs. The lungs look like they are unlabored. We have a regular heart rate and rhythm. There are some systolic murmurs and carotid bruits that are listed there too. Under the external or the EXT, we have the large pink area noted on the left shin, warm to the touch, and then there is the non-pitting edema that's listed there. So now we have the plan. So we have the chest pain, and you can see there that they're sending the patient out for evaluation. Based on how this documentation is worded, it appears that they want that patient to be evaluated now. They're talking about contacting that patient's daughter to determine whether the daughter is going to come get the patient or whether they should use an ambulance then to transport that patient. We have information there on the diabetes. We don't have information, though, on the patient's goal, where they want this patient to be. We do have an order to report if the fasting goes over 200 and the non-fasting goes over 300. They discuss the medications themselves. There's an order for an A1C to be drawn in December. We have the cellulitis of the left lower extremity, status edema. We don't have information again about how long this has lasted or how long it is expected to last. And we do have an order of medication for about 10 days. We also have an order for a lipid panel, and we have instructions concerning the patient weight, and this seems like it is stable. They're continuing the Lasix that the patient is on and also continuing an ACE wrap for that leg. We have a total time of 50 minutes that has been spent on this particular patient. So the procedure code was submitted as a 99350. Well, the 99350 requires 60 minutes to be met or exceeded. If coding is based on time, this would be the 99349. When coding is based on the medical decision making, and let me back up a second, you can code based on either one. So if the time had been higher than 60 minutes, then that 99350 would have been the correct procedure code, regardless of what we find within the medical decision making itself. As such, though, we only had the 50 minutes, therefore that's the 99349. When we're looking at the medical decision making, we do have a high problem because of the chest pain. This is the first time that the provider has heard about this. Even though the patient was not experiencing chest pain at the time of the encounter, this is really something that would need to be looked into. So this would qualify as one acute or chronic illness that poses a threat to life or bodily function. The provider also mentions the left calf edema. Now, again, they do use the term chronic, but has this lasted 12 months? Is it expected to last the 12 months? So we have a high problem, we have low data. We do have a mention of an A1C from 915, but we don't have any information about who ordered this. If it was the same practitioner, then that A1C would have been counted within that 915 encounter or possibly a previous encounter. We wouldn't count this since the documentation really doesn't show us who ordered that and what were the circumstances behind that order. They are, however, ordering another A1C to be performed, and they are ordering a lipid panel. So this would count for the data of low. Under the risk, we counted this as moderate. We have the provider making changes to the medication. We have the provider determining the patient needs additional care now. There is a notation of that discussion on how to get that patient for further evaluation. Again, it doesn't appear that the patient necessarily is in an emergency situation right this moment or at the moment of the encounter, but the patient does need further care based on that chest pain. We did not count that as high risk since the patient was not experiencing the chest pain at the time of the service. That chest pain was a few days earlier. So now we want to open it up for questions. And we have a couple of pre-submitted questions I'm going to go through first. And the first one we've kind of already talked about, but I really want to re-emphasize this. Providers are asking what additional pieces of information you have to have in order to do an E&M service in the patient's home. And there isn't anything special, I guess you could say, about doing a service in the patient's home. You still have to meet medical necessity. You still have to meet the documentation to cover your level of service. But the fact that you're doing the service in the patient's home rather than in another location, Medicare doesn't require anything specific for that. It could be a convenience for your patient to be seen in their home as opposed to them coming to your office. It could be that your practice is simply doing services for patients within their home. All of that is acceptable to Medicare. And then the other excuse me, the other pre-submitted question we have is, can you do mental health services in a patient's home? Now, this presentation today is not geared toward mental health services. It is strictly dealing with the E&M, but the short answer to that is yes. And we do have a playlist in our YouTube channel that goes or that talks about different aspects of mental health. And I believe we have one that would cover that location. So again, short answer is yes, you can do services in the patient's home. Rachel, do we have any additional questions?
Yeah, we did get one question. So can you please reiterate why example 1 and 2 did not qualify for prescription drug management?
Sure. And as I stated earlier, this is an area, a big area of confusion for providers. If you look at the AMA directions on how to choose your level of service, and the AMA has this available on their website, but they also have it within the CPT books themselves. The items that are listed within that risk category are not automatic. They are simply examples. They have additional information in narrative form that discusses the risk. And so what your practitioner has to do is evaluate the patient's risk from the decisions that they're making, and then the conditions that the practitioner is treating. Excuse me. So in example 1 and example 2, there are prescription medications that have been ordered, but there's no indication within that medical record itself, either by a direct statement by the physician or the practitioner, or by documentation just that's part of the medical record, that continuing to take the Zoloft, continuing to use that lidocaine patch, taking the Tylenol will be a risk to that patient. In the example 1, well, for both examples actually, the medications are things that the patient has already been on. So it's not a new medication. It's not where the practitioner is going to be looking for individual side effects or the patient's reaction to that medication, as opposed to looking at the efficacy of the medication itself. So as coders and billers and auditors looking at the medical record documentation, for that risk category, you have to verify that the rest of the documentation supports the risk that you're assigning to that. Under the 1995 and 1997 documentation guidelines, things were a little more straightforward, I guess you could say. If you evaluated so many systems, if you ordered prescription drugs, it automatically went into a particular category. For the new guidelines, that is not the case. It is examples only, and the remainder of your documentation has to support that level of risk. So Rachel, anything else?
No other questions.
Okay, on behalf of Rachel and myself, we want to thank you very much for your attendance today. Again, we have recorded this. We will be placing this on our Encore page on our website, and then also on our YouTube channel. We do encourage you to share that information so others, if they weren't able to be here today, can take advantage of this education. We do have, based on the questions that we have received, based on suggestions that we have seen in the surveys, during the month of February, we are doing 4 additional presentations, one specific to choosing your level of service based on time, another discussing the problem, another the data, and then the last one will be the risk. So we do encourage you to register for those. It will be brief presentations and then kind of taking your questions. So thank you very much for attending today, and you can now disconnect.